Well, hello everybody. It's nice for you to see me if I can't see you. I'm sorry I can't be there in person. Some of you may know that I've been having to have some surgery this spring, and although I didn't know then when it was going to be, it turns out that it is going to make it impossible for me to come and see you. I very much enjoyed coming last time, although, as you know, I was rather sick then as well. I thought that what I'd do in this short talk is to just tell you what I think has been happening and what's exciting about CLL over the last year. And there are two things that have happened in the last 12 months which I think need to be drawn attention to. One of them is the fact that there are new guidelines been published, which Michael Halleck was the chief author, and the other thing is the German CLL-8 trial, of which Michael Halleck was the chief author. And I'll just say something briefly about these two. As far as the guidelines are concerned, the most important thing about them is that a lot of people who thought they had CLL really don't have CLL at all. This is because the threshold for diagnosing CLL has changed. Back when I started being interested in the disease, you needed a lymphocyte count of 15,000, and then it dropped to 10,000, then to 5,000. Well, as of last year, you need 5,000 B lymphocytes, and that makes quite a difference, because normally the majority of your lymphocytes are T cells, and in fact most people with CLL have increased numbers of T cells. So if you have 5,000 B cells, your total lymphocyte count is likely to be of the order of 10,000. And so a lot of people who previously thought they had CLL are now being recognized as having monoclonal B-cell lymphocytosis. Now this is something that I've been going on about for a few years, and Victor Hofbrand and I wrote an article about a couple of years ago saying that there are some people who've been told they've got leukemia who are never going to have any serious illness. And this is this group who've got rather low B lymphocyte counts, less than 5,000. We recognise that it's quite a common condition. Monoclonal B lymphocytosis occurs in about 3.5 to 4% of people over the age of 40. And if you've got CLL in your family, it's over 12% of people who've got familial CLL in their family are going to have this monoclonal B-cell lymphocytosis. And it's quite unusual, about 1% a year of such people developing full-blown CLL. So a lot of people who've been told they've got CLL really don't have it now, and that's, I guess, one of the most important things for lots of people. As you know, CLL often gets labelled the good cancer. Well, once you take out all those who've really got monoclonal B-cell lymphocytosis, it's not such a good cancer as people think of it. So that's the most important thing that came out, I think, in the last year. The other thing I want to say that comes out of the guidelines is about staging. Now, I know a lot of people in America, I don't know if there's so many in Canada, but a lot of people in America certainly are getting lots of CT scans. And the new guidelines make it very clear that CT scanning for the usual patient has really got very little to do with diagnosis or management. There's a lot of scares around that CT scanning is dangerous because you get a large dose of radiation. And that's been a bit exaggerated too. People say it's worth 400 or 600 chest x-rays to have a CT scan. But that's because a chest x-ray is very little radiation at all. If you compare it with, say, an x-ray of the abdomen, or an abdominal x-ray is worth 75 chest x-rays in terms of radiation dose, because your chest is mainly air, and it doesn't stop the x-rays at all. And therefore a CT scan, well, it's worth 6 or 7 abdominal scans, but it's not such a huge dose as people worry. So I think there's an exaggeration of how dangerous a CT scan is, but nevertheless, multiple CT scans do deliver a fairly large dose of radiation, and it's probably not necessary for most people to have CT scans at all. The staging of CLL, calling it 0, 1, 2, 3 or 4, or stage A, B or C if you're European, has nothing at all to do with the CT scan. In fact, having a large spleen on CT scan doesn't make you a more advanced stage, because the staging is entirely determined by what you can find on clinical examination. And on clinical examination you have to have a very large spleen indeed before you can feel it. And therefore a lot of people think they've got enlarged spleens because they've had a CT scan, but in fact they don't have large spleens at all according to clinical staging. And that, I think, is very misleading, and it's one of the things that is really advised against in the new guidelines. There are circumstances where CT scans are necessary. It may be necessary because you could have abdominal glands which can't be felt, and they may be important. And it may be necessary if you're going to take a measurement of whether or not the disease has changed for a clinical trial. But if you're not doing a clinical trial, if you're just having normal treatment or normal staging, then CT scans are usually not necessary, and I think should not be used at all in most circumstances. And I know a lot of people have had these CT scans. They write to me and tell me that they've had a CT scan, and I keep saying, why? You should not have had it. So that's another thing that the guidelines have taught us. Well, there are things in the guidelines which I disagree with still, but I'm not going to go into that tonight. What I really want to talk about, apart from that, is beginning treatment. Now, the first thing to say about beginning treatment is that it's very unlikely that your CLL can be cured. And so you have to make a judgment as to whether you're going to benefit from having your CLL treated. And many patients are on a watch and wait program. The disease is being watched to see if it changes, see if it gets worse. And a lot of people, although the disease may get worse, it gets worse very slowly, and you really don't need to have any treatment at all, at least for a very long period. So this treatment decision that has to be made is quite a difficult one. The guidelines give us some clear indications as to when treatment should begin. A lot of people get treated because they're tired. It's a very common. Now, I don't want to dismiss the fact that people get fatigue from their CLL, but on the other hand, the fatigue that justifies treatment has to be quite severe. It has to be such a stage, that such severity that you're not able to go to work, or you're not able to carry on your normal activities. And therefore, it's very easy for enthusiasts for beginning treatment to say, oh, you're tired, let's start some treatment. I think we need to be careful to follow the guidelines. All the results that we get from our clinical trials are dependent on entry criteria to those trials which follow the guidelines. And if you get treated outside the guidelines, then it means that you can't look at the results from the trials and apply them to yourself, because you're going to get different answers. So it is very important that people are not treated, because there's a downside to treatment as well as an upside. As I said, treatment doesn't cure very many people. In fact, I'd go as far as to say the only way we know of curing chronic lymphatic leukemia is by a stem cell allograft. And that is such a dangerous proposition that may well kill you before you would have died otherwise from the disease. And therefore, having a transplant is a very difficult decision to enter into, and has to be taken with advice, by very careful consideration as to whether it's the right thing for you. Other forms of treatment are really designed to give you longer remissions. If we look at all the treatments that are available for CLL and all the trials that have been done, they give results. Different types of treatment give results which give you a longer remission, but none of the types of treatment given as first line is going to give you a longer survival. And that's because usually you can have several bites of the cherry. You can have this treatment, then that treatment, and there's no evidence at the moment that having the treatments in any particular order is going to make you live longer. Now that may emerge as we have longer follow-up on the trials that have been done, but at the moment it really doesn't matter, as far as we can tell, as far as survival is concerned, which treatment comes first. However, it's clear that some treatments give you longer remissions than other treatments, and one of the things that's clear last year from the German CL8 trial was that adding rituximab to FC does give you a longer remission. It may give you a longer survival, but we don't know that yet, and we'll have to wait and see how the trials pan out. We shouldn't despair though. Even though current treatments are not able to cure the disease, we're seeing treatments that get rid of more and more of the disease. We have techniques now which detect very small amounts of the disease, and we can treat until the disease is undetectable by these methods. And certainly when this happens, patients seem to live longer. However, final outcomes still remain to be determined. The other thing to say is that there are a lot of new treatments out there that are undergoing trials, and I just want to mention one of them which I've just learned about yesterday actually, and that's AZT2881. This is a PARP inhibitor, and it's targeted particularly at a very difficult to treat group, those patients who have a deficiency of their long arm of chromosome 11. These patients, or who are ATM mutated, is another way of defining them, have a poor prognosis. But this drug seems to be targeted specifically at them, and trials are about to begin in the UK, and I really think that this is going to be a great advance. It may well be able to be combined with other effective treatments, and we may well see, as a result of this new agent, better survivals. But there are lots of other drugs too, and I'm sure as this conference goes on you'll hear lots about them. So there we are. In Bournemouth just recently we've had Canadian winter-like conditions with snow, but I think spring is almost here. I'm hoping that there in Niagara you're having wonderful weather and that you really enjoy your conference. So best wishes to you all.